Good afternoon, everybody. Welcome to the LEAP Zoom webinar on what should optimal primary care teams look like. Welcome to all the LEAPsters. In addition, I want to introduce our presenters and special guests. We'll start this session with two presentations. The first by Dr. Lisa Leroy, a principal with Abt Associates U.S. Health Division, on an AHRQ project recommending the configuration of optimal primary care teams under different population characteristics. The other presentation will be given by our own LEAP Deputy Director, Brian Austin, who will share with us what we've learned about the composition of the 30 LEAP practice teams. They will be followed by some quick reactions from Margaret Flinter, co-director of the LEAP program and Senior Vice President at Community Health Centers, Inc. in Connecticut. Dr. Bertie Safford, formerly Medical Director and Distinguished Senior Citizen of Family Care Network in Bellingham, Washington. And Roseanne Matzik, Care Coordinator from Vibrant Healthcare in River Falls, Wisconsin. And then we're going to open it up to everybody. Just a word, this is different than your typical webinar. One, the presentations will be brief, so most of the time of the hour will be spent hearing from all of you. Two, in a typical webinar, there would be 5 minutes left at the end for questions. You would type them into a chat and hope that your question got addressed. Here, you raise your hand, you will speak your mind, whether it's a comment or a question, and we encourage all of you to join in. We have special guests to announce. We have two who were instrumental in the AHRQ project. The first is Dr. David Myers, who is AHRQ's Chief Medical Officer. Welcome, David. And Michael Baylett, a longtime colleague and president of Baylett Health, a consulting company. And Michael knows more about the financing and payment of primary care, in my view, than almost anybody in the country. So we're delighted to have them join us. With that, I'm going to turn it over to Anna Rogers at CHC to tell us some of the ground rules. Anna?
Thank you, Ed, and good afternoon, everybody. If this is your first Zoominar, I just want to quickly go over how you can participate in today's webinar. So the first is, as Ed said, you can submit a question using the Q&A button or the chat button. You can certainly use the chat button to sort of talk amongst yourselves, but we'd really like to see and hear you. So if you would like to become a panelist, as you can see, there are just a few faces on the screen now. If you would like to join the conversation, send us a quick message using the Q&A button, and you'll see at the top right corner there's a little box that will pop up. You can type in, could you please add me as a panelist, and we'll promote you to a panelist where we can see and hear you. You just need to make sure that you have a microphone and a webcam. If not, you can dial in. There are dial-in options. If you go to the bottom left-hand corner of your Zoom screen, that will give you the options to dial in if you do not have a microphone on your computer. And that is how you can participate. But again, feel free to send questions in using the Q&A if you do not have a microphone, and I will be tossing out questions throughout. And I am turning it over to Dr. Lisa Leroy from Abt Associates. Lisa?
Great, thank you. Thank you for the opportunity. So I am going to briefly go through some work that was funded by the Agency for Health Research and Quality. Next slide. And what we did is we developed what we call optimal models of primary care for teams that want to deliver high quality, comprehensive primary care. And I don't think I need to say anything to this group about why think about developing primary care models. But I do want to mention that that we wanted to create kind of a benchmark is probably too strong a word, but we wanted to come up with a model that could be used by a whole variety of different people, payers, providers, policymakers, to compare what they were doing with what would be a comprehensive, high quality care team, a team that could deliver high quality, comprehensive care. We also thought this might broaden the discussion about workforce and workforce shortages, and maybe thinking more broadly about the type of people that would be needed on a team. And then also to think about what should policymakers be thinking about how much primary care costs. We know that primary care is a small fraction of the overall healthcare budget in the United States. And you know, if primary care was able to deliver high quality comprehensive care, how much would it cost? Next. So this is our study question. What is the optimal workforce configuration for a practice that aspires to provide high quality comprehensive primary care? And we looked at, we tried to develop models for 4 different patient populations. One being kind of a typical average population, one with a high proportion of geriatric patients, one with a high proportion of social needs, and then a rural group. Next. This was our methods, and we defined high quality comprehensive primary care. There's a white paper, and I have the link in one of the slides if people want to take a look at that. From there, we moved into thinking about the care functions and roles needed on a team. Then we translated those into actual, types of staff and numbers of staff. And then Michael Bailett did his magic and estimated the cost of each model. And I just want to say that this sounds very linear, but it wasn't. It was a very iterative process. And the data sources, we relied on an expert work group. We had a very large work group, and we also consulted with a lot of experts around the country, many of them involved in LEAP. We looked at the literature. We pulled workforce data on 73 innovative primary care practices. 30 of them were LEAP sites, which is not a surprise. We did 8 case studies to primary care practices that were doing some function in a very, performing some function in a very kind of unique, high quality way. And then we had on our team the McCall Center, Ed, and so there was a lot of knowledge from other related projects. Next. So these were just some of the, we had to make a lot of assumptions to come up with the models. And so these were the assumptions that we worked with. We said that we wanted this practice to be able to take care of 10,000 adult patients. We didn't include pediatrics because just the scope of the project. And that was actually turned out to be a somewhat typical practice size when we looked at the national data. We said that in this average or index model, 32% of the patients would have multiple chronic conditions. We were sort of thinking about what the population is going to look like in 2020. We said, there's a growing over age 65 population. There'd be about 17% that would be on Medicare, about 20% on Medicaid. Again, we're using kind of today's nomenclature. And then we had developed a framework of a high quality comprehensive care. We said all of the capacities in that framework would be present on the team. We assumed a high functioning team that works together, collaborates, utilizes expanded roles and standard work, uses team meetings, huddles, minute-to-minute interaction. We assumed that behavioral health and medication management were in the team, integrated into the team, and that this primary care team had relationships with community organizations and would therefore be able to make linkages with community services. Next. So this is what we came up with for our index model. So you can see if I just go down the functions on the left-hand side, there were 8 primary care providers, 6 physicians, 2 nurse practitioners, 1.5 RN, which we consider to be kind of a team nurse who would supervise the medical assistants, of which there would be 9, 1 working with each primary care provider, and then 1 to float and cover for vacations, maternity leave, things like that. We allocated 2.5 nurses to do the complex care management for those adults who would need it. We allocated 2.5 social workers, 8 clerks, 1 pharmacist, and then we said that we would need 0.3 of an FTE physician leader to kind of lead the team in thinking about quality improvement and optimizing HIT. The actual staff who would be doing a lot of the, report running and analytics and things like that were included in the overhead costs. But we felt that on the team, there needed to be leadership for those functions. And we made a similar decision about leadership for population health, reports and analytics and team meetings and things, coordination, things like that. And then for self-management support, we said 1.5 health coach. So the total staff were 36.8. And that turned out to, next slide, please. So that turned out to lead to what we called primary care provider actively managed patient load, which you can see on the second row here, of physicians having about 1,333 adults that they would actively manage. They would see them at least once a year. The nurse practitioner workload or cohort was about 1,000. And I'm deliberately not using the word panel here because panel is defined so differently by every payer and health system out there, and there's been a couple of papers written about the inaccuracy of panel sizes. So we really wanted something that would be a reasonable workload for a primary care provider that would leave them enough time to meet with the team, to have those kind of collaborative conversations that you need, and that your day would be a real work day, an 8 to 5 or an 8 to 6 work day, but not where you're doing 2 hours of paperwork in the evening. And then just the side-by-side comparison, you can see that here we have the high geriatric or high multiple chronic conditions model, the rural model, and the high social needs model. And we varied the staffing for each of those models based on what those patients' needs would be. And I don't want to go into gory detail here, but you can see, for example, if you look at the behavioral health integration line, that we have a higher number of behavioral health providers, professionals in the high social need model than we do with some of the other models. And I should also point out that the rural model we based on a cohort of 5,000 adults, and we assumed that the talent pool it would be a resource scarce area, and that you would need to make more substitutions among different kinds of health providers. Okay, so why don't we go to the next slide? So these were the costs for each of the models. And you can see that a cost per patient per month, the bottom row, for the index model, it was about $45. And then it varies by the type of patient cohort that you're taking care of, obviously. And the range at the bottom is to just do a little bit of sensitivity analysis around the fact that salaries differ a lot across the US. And in some labor areas, salaries are lower, in some areas they're higher. So we wanted to give a range just to show, how the cost could vary depending on where you sit in the US. And I guess the last thing I will say is that these are higher than some of the health plans that we talked with. These are higher per patient per month costs. That wasn't a surprise to us because we have a richer set of a richer team here, and assumptions about providing a comprehensive set of services, so that there's not a lot of referral, that the team is really caring for, as many of their cohort as they can. Next. So these are some resources, the white paper on definitions of high quality comprehensive care, and then the site visit reports for the 8 sites that we visited. And that's it for presenting the ARC models.
Thank you very much. We have just a minute or two for clarifying questions. Hold your comments and longer thoughts for later, but if anybody wants Lisa or Michael or David to clarify something, now is the time. Well, great. Thank you. Let's hear from Brian and what we learned from the 30 LEAP sites. Brian?
Thanks very much, Ed. Let me just start by saying that Paula Blasey, who is seated to Ed's right on the other side, is well, I'm responsible for any mistakes, but Paula is responsible for a lot of the cleaning, interpretation, and visualization work that we've done so far with the staffing data. And so a lot of this represents her work as well as mine. And if you have questions.
And the sites work.
And the sites work, yes. So if you have questions, we're as likely to turn to Paula, or more likely than to turn to each other. Next slide, please. It's important to just reinforce that we saw the LEAP practices through the lens of core and extended team members. And I know we've shipped you a glossary, Leapsters, and when we've done you for data, we've reinforced this. But just to say it one more time, core team members are individuals working with specific PCPs on defined populations of patients, defined panels. Extended team members are staff who also have a professional relationship with the core team, but they may be working on specific subpopulations or provide services across the practice, but they're not the day-to-day core team, and that's important as we look at our data. There's centralized staff that aren't in either of those, so this was not meant to represent back office staff, billing staff, people like that. Next slide, please. So here's the briefest possible look at core team staffing by role. You can see among the 30 LEAP sites, everybody had medical assistants, everybody had panel PCPs, about a third of the teams had a team RN, an equivalent number of teams had front desk or administrative staff who were viewed as members of the core team. They might be doing paper management, they might be doing patient management, but they were tightly aligned enough so that they were viewed as core team members. And then you can see the range of core team members. And again, this is site visit data. So this is what we saw when we came out and visited you in 2013. Next slide, please. For the extended team, obviously, it's a bigger cast of characters. So we'll leave this up for just a minute. You can see that there were a significant number of roles that were filled in a half to a third of the practices. Referral coordinators, pharmacists. Then there were a number that I put in the little corral there to the right that had fewer than 7 mentions among the 30 teams. And those were health coaches, students. For the site visit data, we know who those students were, if they were pharmacy students or other disciplines. We were interested that in the survey data that you filled out for us later, you had a significant number of student ads as well, and we'd love to hear what kind of students you've been adding, and we'll get to that in just a minute. Next slide, please. So Paula and the team and I have been trying to kind of visualize a team composition. And it turns out there's lots of ways to deliver good care. Again, we've been thinking of it in terms of the core team, which is the inner circle there, and the extended team, which is the outer circle. And one just caveat, the inner circle, for those data, we have FTEs. So when we represent a half a slice of medical assistant and panel PCPs, we mean a one-to-one relationship. For the outer ring in the 3 slides you're going to be seeing, that's really just that the role is represented. We don't have FTE data, so it just shows that that capacity, that function is filled by the extended team. So this is for the Ellsworth location of Vibrant Family Health Clinics in Wisconsin. Pardon?
It's Roseanne's practice.
Roseanne's practice, all right. There's a degree of customization to how we're gonna tie this in. So this in 2013 represented 1 core team, but it had 3 PCPs and 3 MAs to serve a predominantly fee-for-service practice. So we have 30 of these plastered on our conference room walls, and this is the simplest. Next slide, please. Here's another core team that's just 2 roles, although it's not a dyad. There's 2 PCPs per team, 3 core teams at Cabin Creek Health Systems in West Virginia. This was the Clendenin site. But in this case, there's a larger number of extended team roles represented in the practice. And so you can see that there's just more functions to draw upon. This is an FQHC that's a significant amount of Medicaid business and a significant number of uninsured that they're treating. And next slide. This is one of our more complicated team compositions. So this is 11th Street Family Health Services of Drexel University in Philadelphia. This is 1 core team, 4.5 nurse practitioners, again, an even higher number of Medicaid and uninsured. And you can see there's a whole constellation of people, of functions that are supporting the core team. But the core team itself has behavioral health specialists, has a team RN on it, in addition to panel PCPs and medical assistants. So that just gives you some flavor of the 30 different slices of teams that we saw when we went out and did our site visits in 2013. On the next slide, you can see staffing changes. So we harassed you unmercifully for updated information, and we asked what are changes to your staffing. Now again, this isn't site visit data, this is your self-reported data, and we've collapsed core and extended team. We did give you a glossary of terms, and so we hoped that we were referring to the same thing for a referral coordinator versus a care facilitator, for instance. But you can see that the net change in the 30 sites from 2013 to 2016. Referral coordinator is, highest in the number of ads. We've got, as I mentioned before, a significant number of students. And we'd be interested to know what roles those students were playing. We have some roles that went down, including care facilitator, which actually dropped among the 30 sites by 6 sites. But this gives you some flavor of the stability of the teams. And again, thank you so much for responding to Paula, to Sarah, to Leslie, and myself when we asked you for updated staffing data. And it shows both what stayed the same and changes that you're making over time to try to get to the mythical perfect primary care team. So that is a whirlwind tour through a slice of the LEAP practice data. Ed?
Are there clarifying questions for Brian or Paula? I have one. I'm not sure that folks on the call will know what a care facilitator is. Paula, what's a care facilitator?
Yeah, so this is a term that we came up with because there's a lot of variation in the way that sites described a role that seemed to be sort of similar across sites, but they use different terms. So sometimes it was called a patient navigator, sometimes the community health worker, care coordinator, but typically it's someone who is trying to help patients sort of navigate the health system, address problems and barriers. They might help with insurance enrollment, follow-up, and they're usually a layperson without clinical licensure or a traditional health background, but they could be an MA.
Thanks. So they may be called something different.
Correct.
And that decline may very well just be a more specific name change. Any other questions for Brian or Lisa? If not, let's go to our starter fish. We've in a fish bowl, you gotta have some fish. And our first fish is our own Dr. Margaret Flinner. Margaret, what are your thoughts on hearing these two presentations?
Well, hi everybody. It's great to be here. And my first thought is how remarkable it is that without executive fiat or legislation or the Joint Commission telling us we had to, how remarkable the convergence and the agreement is. So when we talk about the mythical perfect team, as I listen to Lisa and to Brian, and think back on my experience with LEAP as well as my own experience, there really is a tremendous amount, I would say now, of agreement and convergence about what you need for a team. And I think, Lisa, you have added a really great feature along with your colleagues by saying, and that team probably looks different based on the population. Certainly as somebody who speaks from the perspective of the federally qualified health center world and vulnerable populations, your index of what that patient population needs and the 11th Street and Cabin Creek practices that we described really fit into that category, and you see attention to the social needs. And if you went out further, many of those practices would also include specifically substance abuse providers or people who are really there to help people more with access to things which are affected by the social determinants of health. But I think the big point for me listening is how much convergence there is. Your list, LEAP's list, my list, the list of practices I know look incredibly similar. In some places, combining functions. The core team and the extended team in some practices are combined into one, but when I look at the ratios, if you kind of add them up, they really, again, look very similar. So I think I want to flag that this work, which is now represented, I think, in very good descriptive information about teams, I don't think could have been accomplished if so much earlier work hadn't gone on and thinking about panels and empanelment, and with all, you know, I'll have to factor in now you're thinking about the cohort, Lisa, and the effect that may have as a different way to think about, but the concepts of panels and pods, of roles, of people practicing at the top of their license, of being trained to those roles, all that work that happened, you know, starting maybe the late 90s and on through the last 15 years gave rise to that. Just a couple of quick points that I wanted to make. One, I think we have to tell our patients this team is here. I'm not sure most patients get introduced to the fact that there is a team wrapped around them, that those people have names, those people have roles, and what they do. And I think that's something that we need to make manifest in our material about our practices and not just be listing the name of the primary care provider. Two, I'm so glad to see the attention to students and residents. I say this all the time, if we don't train people to a high performance model of team-based care, how can we expect them to go out and practice in that way? And so seeing residents and students so well represented in the LEAP material, I thought was really great. The third is to remember the virtual and the offstage people who are on the team who are not as explicit, but that referral, those 11 new referral coordinators are referring to somebody, either electronically through a virtual visit, through an e-consult, or in person. Those people who answer the phones ideally need to know when somebody's calling, everybody who's on that patient team, so they can get them to the right people for the right reason. And then last, because I know my 2-minute clicker is clicking to my right and my left here, I want to just make the comment that I think we all started down this work of teams because we knew we needed a better structure and a better framework to take care of our patients. Having arrived in 2017 with the entire country shifting towards value-based care, shared savings, quality-based revenue, I think it's a really good thing we started this work 15 years ago, because we could not have pivoted on a dime and started now in the new payment structure. We really needed to have done all this work for all the right reasons to take better care of our patients, but it serves us well in the new environment that we're moving forward in. So I will stop there. Yep.
I'm going to call on Bertie in just a minute, but I hope those of you with questions or comments are letting Anna and company know that you're in line. Bertie, your thoughts?
So I will jump in here. We have done some modification over the last few years of our team. Just to frame, I'm in a private practice, so our site has approximately 6 full-time practitioners that are really more bodies, because some of us are part-time, and then we're part of a larger group without practice. So our core team has evolved to be approximately 1.5 medical assistants per full-time, mid-level, or physician. We use LPNs and medical assistants kind of interchangeably in this sense. We have 2 major teams in our 6 practice site. And in addition to the core team of 1.5 per full-time person, our extended team includes an RN supervisor and an LPN who does phone triage. So I was asked to talk about lessons learned, and I think the biggest lessons we have learned is that we have evolved at the level of the core teams into more sharing of the responsibilities, and it's worked really well. So each day, the clinician, the doc or the mid-level, has a full-time roomer who is kind of glued at the hip and rooms patients and handles all the issues related to the patients that are actively being seen. And the extra, quote, 1/2 medical assistant per person is on what we call desktop. So they do all the background things for all of our team's patients, which means prescription refills, non-urgent phone calls, prior auths, lab orders, on and on and on. And in the background, they manage to get all those things done in the course of the day. The second learning is that most full-time practitioners in our practice 4 days a week. So our clinical staff mirrors that, which means they work a 10-hour day, which means they're here until 6 in the evening. And that lets them clean up all the leftovers when we're done seeing patients between 5 and 5:30, so that we go home with a pretty clean desktop to come back and face the next work. And I think everybody has felt a little more peaceful with that scheduling. The final learning is a new learning, which we are wholeheartedly embracing, and that is the function of scribe. We have struggled throughout not just our site, but all the other sites in how we combine helping get things entered into the medical record with all the other work that falls to the core team and our clinical assistants. So since December, we now have decided that scribing is actually not one of the core team functions. And we have contracted with a scribing company who hires and trains scribes for us. And then they come and work with a particular clinician so that each one of us has one dedicated to us who learns our habits and foils. And they don't participate in any other way on the clinical team. They simply follow us into every room, do the charts while we interact with the patients, place the orders, the labs, the prescription refills when we're in the room with the patient, so it's not hanging over us at the end, and then come out with us. And that has then freed our clinical assistants to do their job. What we've learned is the people that are hired for scribes tend to be a different sort. They're mostly pre-med or pre-dental or pre-nursing students. So they come with a lot of health background and a strong interest in it, which is a different level of person than trying to train a medical assistant to do the difficult task of integrating a conversation and charting physical exams that are being verbalized. So that is how we are making our teams work, and so far it's been a major step forward.
Thanks, Bertie. Roseanne, thoughts?
Hello.
Hi.
So what I've learned from our new the team care, we needed to add staff. We weren't adequately staffed in Ellsworth, so we've added a float position. We've added somebody who does the message center each day, which takes care of all the med refills, all the messages that come into the clinic. So that was one of the first lessons we learned with team care, is that we couldn't handle the patient flow adequately with the one clinical staff person per provider. So now we have that extra staff, actually sometimes 2 extra staff, to help us. Another thing is the communication, those daily huddles. As soon as you stop doing the daily huddles, we could tell that's when problems would arise. You can't be too busy in the morning to not have that huddle, that communication time with your providers and staff. That has to be a priority of every day, because things go south fast without having that open communication every day. We also noted that we needed the care manager. I'm a CMA care manager. We call them at our clinic a care coordinator. They have to be embedded in the core. They can't be extended. They have to be embedded in the core team. There's too many missed patient opportunities if you're not there to have the access to the provider, easy access to the clinical staff. So that's one thing that we've really learned that we have to have in our staff. Another thing that we're doing now is starting our scribing role. We've just begun that in River Falls. Maybe be extended into our Ellsworth thing that helps free up the physicians. And then also the healthcare providers are becoming more active in educating our clinical staff. They're scheduling time aside to teach them about chronic diseases and their role in caring for a patient. So that's been very helpful, we found, is to have the healthcare providers actually engaged in the education of their CMAs. Another thing that we've just started thinking about and starting to implement is our quality data review. Set time aside with the clinical staff, with the whole core team or the whole extended team to review our quality data. Are we slipping? Are we getting better? What do you see as a CMA or as a care manager? How can we improve our quality data? So that's something that we're just beginning to work on. Also, because of the way our role was doing, the care coordinators or the case managers weren't meeting regularly with the physicians anymore. We used to set time aside with the healthcare providers, with the clinical staff, and sit down and review our whole chronic disease panel. That kind of went by the wayside, and we're finding out that that needs to get reinstated. We need that time to sit there and talk about individual patients. So those are kind of the learning things that we have had.
Great. Great points, Roseanne. Thank you so much. Some major themes have already emerged. Maybe the need for more than one medical assistant per provider to increase efficiency and get all the work done. The advent of scribing. One point in Brian's slides that I wanted to emphasize was the growth in the number of pharmacists and the number of behavioral health providers, which reflects, I think, agreement with the ARC model, which says that pharmacy management and behavioral integration are now considered core elements of a patient-centered medical home. Who else wants to join the conversation?
Hi, Ed. Can you hear me?
Could you identify yourself?
No, it's much more interesting this way. It's Kirsten. Hi, guys. It's nice to hear everyone's voice. It's Kirsten Meisinger from Cambridge Health Alliance. And is anyone else wowed by the sheer number of people it takes to make our medical system function in primary care besides me?
I think we all agree.
I am very wowed. And for those of us in private practice, it's a little bit staggering, actually. I think that's one of the reasons you don't see more behavioral health and pharmacy and care managers is those of us limping along in the fee-for-service world still.
Anybody else have a comment?
Hi, can you hear me okay?
I heard a voice.
Hi, it's Noah Nesson here at Penobscot Community Healthcare in Bangor, Maine.
Hi.
How are you?
Good.
We had our own HRQ initiative for 3 years. It's over now, in which we funded an extra half FTE of an MA for every provider. So every provider, in the pilot groups, every provider had 1.5 MA support. And in addition to the kind of role that Bertie described, they did a lot of gap in care work and previsit planning. And as a result of that work, we were able to show dramatic improvements in quality, significant improvement in provider and primary care team satisfaction, improvement in patient satisfaction. What we couldn't show was improved productivity, and I think it's common sense. Why? Because we long ago surpassed the capability of our primary care teams to meet all of our expectations of their visit. Getting back to Kirsten's comment that it takes a lot of people to do the things that we want to do for our patients and our panels of patients, and that's in a practice in which, separate from that, there are people doing prescription refills whose only job is to do prescription refills or prior authorizations and that kind of work. So I'm not sure we've even discovered where the sweet spot is for staffing if we really want to do this well. But it does make, as you pointed out in your publication, without empiric evidence of a return on investment that reassures CEOs and CFOs, it continues to be a challenge to support investing in these models going forward. We've done other things as well with clinical pharmacists, and that in the past, and now clinical pharmacists paired with care managers, which is a really impactful intervention. But it's always grant supported and temporary.
Great comment, thanks. Anybody else want to add to the conversation?
Well, if I could.
One thing I've been.
Go ahead.
No, you go.
I quickly respond to Noah. Hi, Noah, up in Penobscot. I think that as long as the return on the investment has to come from increasing productivity, we may all run into that same brick wall. It's part of why I'm so excited we've done the groundwork to be able to think about the return on the investment, come shared savings, and the achievement of quality goals, because I don't know how else we get there.
Margaret, this is Kirsten. One other thing I've been chewing on, guys, for a while now is, the amount of money that we're investing in medicine around social determinants adds up roughly to the amount of money that other countries that have a different structure for that investment, like say Germany or other parts of Europe, the total amount of money appears to be about the same. But we have this curious habit of routing everything through the medical system instead of addressing the social determinants directly. And I'm guessing, although I haven't seen anything on this, that we're actually getting a lot less efficiency out of our medicalizing of social determinants problem than other countries. But I actually don't know if anyone has thought about that or looked at that. And, Margaret, the idea that we have to always make a profit off of people's misfortune has always bothered me. So I'm wondering, if this value-based shift, which I'm also just very excited about, is going to perhaps start to move us culturally in that direction as well.
Comments? Michael Bailet, all this talk about value-based payment, what's happening around the country, and what is it having the impact that people thought it would have?
Michael, we can't hear you.
Michael, you're on.
Sorry about that. I was muted twice. So there's not a lot of value-based payment that's happening at the primary care level. Where value-based payment is happening is at the ACO level. But frequently that just means that there's a budget target, and underneath it is continuing fee-for-service payment to primary care, specialty care, and hospitals. And unless what I call the payment under the payment changes, so that the underlying payment model is value-based and not just the ACO level budget is value-based, then I don't think we're going to see the type of support for enhanced primary care teams and really transformed care. That help?
I think it's, I don't think it was what people wanted to hear, but I think it's the reality that we're seeing for sure. David Myers?
Yeah, I mean, I am seeing increasing discussions, not just through the CMS CPC Plus program, but in other places. There's increasing interest in returning to the concept of primary care capitation, but doing it in a more sophisticated way. Sometimes that includes a bigger investment in primary care, and certainly that addresses some of the shortcomings of primary care capitation from 30 years ago.
Thanks, Michael. David Myers?
Thanks, Ed. Great presentations, an amazing group of LEAP participants. One of the things in the ARC model that it's based on is not just that there'll be savings that people often look for in acute hospitalizations and ER visits, but we actually believe that the enhanced primary care team that truly moves towards comprehensive care and takes care of a wider range and a deeper range of people's complex problems will save money for the larger healthcare system based on lower referrals and less giving away management of complex conditions to medical subspecialists. And so I'm very curious for the folks on the phone today, do you think that's a good assumption? And have you seen, or has anyone seen, investments in your own staffing leading to more comprehensive care and potentially less reliance on consultations or long-term referrals?
Thanks, Dave.
This is Bertie. I was just going to add my 2 cents. That's one of the tenets that is really important in the family practice that I work in. And as we get more younger members in, I think the issue is the overwhelmness of it all. There's so much noise in the system in terms of prior auths and, you know, all that kind of stuff, that people who are capable of doing more complexity tend to kind of bag out because they're overwhelmed. So I think as we improve team structure and can offload and just get rid of some of that, that will have a huge difference in allowing us to do what we're all really well trained to do.
So, Ed, if I could add to that, I'd note 3 things. One, our research within my own organization and the Weizmann Institute, our research institute, has shown that e-consults are highly effective at, and Noah, you've been part of that group as well, in preventing unnecessary in-person referrals. And the savings is not from the in-person visit with the consultant, it's from the duplicative testing and additional testing and visits to the ER that happened in the 3 months while we were waiting to get a publicly insured person to the consultant. So that's one. The second investment that we've made is in the arena of really intensive training for new providers, physicians and nurse practitioners and PAs in managing what we consider the high risk, high burden, high complexity, frequent things that we see. The patients who have addiction to opioids, patients with complex chronic pain syndromes, patients with HIV, hepatitis C, and a host of other issues, really training people to be able to do that work internally within primary care. And the third is the development, which we couldn't do without this team of both the core and extended people, regularly scheduled integrated care meetings, which are different than our huddles. They're really selecting people regularly now that we have the kind of data we never did before about what are they doing the other 24 hours of their life when we're not seeing them? Where are they visiting for healthcare? Really looking at those folks and trying to do really good planning up front, whether it's the hotspot or people who are most likely to end up in the emergency room, or it's just people who have complex behavioral and primary care needs. So yes, I think the investment in these core and extended teams does make a difference on those expenditures.
And I'd quickly add about e-consults that in addition to the savings, it helps gradually reestablish a primary care provider's role as a manager of a complex disease rather than a manager of referrals to specialists. I think there's some self-efficacy that comes with repeated use of e-consults that's really important.
I would add, this is Kirsten, that for those of us in the safety net, there isn't often an option to refer, and so we've just had to do it the whole time. So I would second everything that Mark Margaret said, we haven't did, but I always admire her studies and they're honest. One of the things we've seen, because we've always just had to do it, is that the repeat visit rate for us has gone way down now that we have high functioning teams. So it can sort of loose correlation to seeing fewer referrals. We're managing complex patients ourselves, but we're actually not doing it as providers. We're doing it as teams now. So my personal visit rate for these folks is way down. And now that we have more of an ACO structure, we went right from sending patients for referrals to actually do consults and chart reviews. And boy, are those efficient. And they are, the high use of those, I think, is actually a good sign, as opposed to making the patient take their information from visit to visit. Because I know that I've been able to step up my level of care now that I have that available.
Is there anybody who hasn't spoken that wants to get into this conversation?
This is Anna. We've had a few questions come in through the chat, so I'll start with some of them, if that's okay.
Yeah.
The first is sites struggling on how to pay for the behavioral health specialists, and many sites do not have expertise available to them. Related to the pharmacist, are some sites forming relationships with other entities to be able to provide that level of expertise?
Well, one we learned in the LEAP follow-up survey is that Brian showed that students were a major add. Often, I don't know how often, but several of those students were pharmacy students. And students come with their preceptors. And so this was, by making their practice available as a student teaching site, it enabled some practices to bring pharmacy school faculty in once, twice a week as pharmacy consultants. How about behavioral health? Anybody have insights there?
I want to give other people a chance to talk, but of course I have a comment if Mr. Video.
The only thing I would say, this is Bertie, about behavioral health, is we really made a major run at this in our site, and we went to the University of Washington, where they have some excellent behavioral health embedded programs. And it turned out that the way they've been successful is they don't charge for the behavioral health services of the social worker and psychologists and all at their family medicine centers, which tremendously augments the services. But in a private practice world where you're only primary care, that's not an option. So again, I think until the funding changes, I'm not too optimistic.
Ed, we have another question that came in from Michael. Another perspective on the ROI for this enhanced primary care workforce might be that such a model may reduce turnover of clinicians and staff because of burnout. Has anyone modeled the cost to a healthcare organization of clinician turnover?
Very good question.
So Michael, this is David. I actually, unrelated to this project, did some work where we're looking at those numbers. People estimate that for nursing staff, the cost is 2.5 times the nurse's salary, annual salary, for replacement and retraining. Physicians can be that or higher. Some estimates, though I think these included specialists, go up to $1 million for the recruitment, hiring, and training and getting up to speed of a new physician. So you're right, if we were able to model or show that these kind of enhanced teams were actually more efficient in keeping their staff and increasing the joy in practice, we might be able to show the cost savings to the system related to retraining. I was also going to ask, sorry, Lisa, if you had any thoughts from the case studies that you did on people doing innovations on how they paid for either behavior or pharmacists?
Yes, so there were two, well, a couple of interesting models, but one is a small private practice in Colorado where they have the behavioral health specialist, the social worker, is actually employed by another group that is nearby. It's in the same town, but who actually sits at the primary care practice, and she bills, but she also does you know, short interventions. So anyway, that's one way that they've made that work. So and it's been extremely successful for them. Some of the other interventions were at community health centers, and I think, you know, everybody's probably about Cherokee. They've got amazing, but they've got psychologists actually embedded with the primary care team, and only scheduling half their day for visits and the rest just doing short, you know, behavioral interventions, consults, and really successful. When we visited there, it was interesting. We met a physician who had been in private practice, fee-for-service, his entire career. He retired from his private practice and then went to work in the community health center, at Cherokee's Community Health Center, because he wanted to sort of give back. And he said that he had, during all his years in private practice, he never had any idea what it was like to practice with a behavioral health specialist, and that he felt like the care that he was giving in the community health center was 100% better, higher quality for having that person with him. He said, you don't know what you know, you don't know what you're missing and what you don't know until you have it. And so anyway, so that was a real, you know, personal reflection. So those are two that come to mind. And Ed, you probably have a bunch from all of the LEAP site visits.
Yeah, arrangements with community mental health centers we've seen. One thing that community mental health centers now are beginning to think about is wanting to have primary care integration into their community mental health center for the severely ill, mentally ill, who stay in the community health center most of the time. And some larger practices are now making collaborative arrangements with community mental health centers of, we'll provide primary care in your center if you provide behavioral health in our centers. And that sort of arrangement, which I think makes a lot of sense. Thank you, everybody. I think we want to end on time. Just a quick summary. I think we heard again and again how critical it is to have a highly efficient primary care core team, because that is so highly correlated with burnout, staff satisfaction, patient satisfaction, and other outcomes. And that the old one-to-one MA physician model might need to be re-examined. Mental health and behavioral health integration and now more sophisticated medication management is I think part and parcel of modern comprehensive primary care. Obviously, we have funding challenges, but nonetheless, practices like LEAP practices are finding creative ways of figuring out how to get those services. Lastly, I wanted to comment on David's point about referrals. The one thing that we have learned at Group Health, now Kaiser Permanente of Washington, over the years about referral rates is they are highly sensitive indicators of staff burnout. That as staff burn out, they refer more. And So monitoring referral rates, I think, is a critical element as we go forward. Thank you very much.
Just one plug for those who are on the call. Please do continue to go to improvingprimarycare.org, our team guide. We know you've got updated tools, updated resources. We continue to add things to the site, and we'd love to know both how you're using it, and we'd love to have your help continuing to improve it.
Anna and her team at Community Health Center, thank you so much. Thank you, everybody. See you soon.